Good afternoon, everyone. This is the case report of Mobius syndrome. Purpose of the study is to study clinical manifestations of Mobius syndrome. Introduction. Mobius syndrome is a rare congenital disorder characterized by unilateral or bilateral non-progressive, both 6th and 7th nerve cranial palsies. It can also be associated with other cranial palsies, orofacial anomalies, and limb defects. The prevalence of Mobius syndrome is estimated to be 1 in 250,000 live births with equal incidence in both sexes. Most cases are sporadic, but familial cases representing about 2% of all affected individuals have been documented. The diagnosis of Mobius syndrome is based exclusively on the clinical criteria, even though syndrome is listed in MIM number 15-1700 with gene map locus of 13Q 12.2 to Q13. Sporadic mutations in PLXND1 and REV3L are identified. Coming to the case report, a 22-year male came to the ophthalmology OPD with complaints of defective vision, diplopia, facial muscle weakness, bulbar weakness, and hoarseness of voice since 1 week. On examination, there is drooping of the upper eyelid. On further examination, there is left eye isotropia with the 15 degree and abduction fallacy is noted. On slit lamp examination, both eyes pupil is round reacting to light and both eyes fundus findings are normal. And CT brain showed mild prominence of the ventricular system. Treatment, lubricating eye drops were advised and the requirement of strabismus surgery at later time was explained. Advised further management of facial paralysis by corrective procedures like temporalis tendon transfer and smile operation. Conclusion, diagnosis of Mobius syndrome is mostly clinical and no specific laboratory investigation is available for diagnosis. Early rehabilitation may enhance the recovery of normal function, particularly in vulnerable areas development. The approach must be multidisciplinary, involving professionals with different skills and with specific training in cooperative therapies. Thank you.
Good morning, everyone. Today I present a case report of morning glory disc anomaly. A 13 years old female patient present to our ophthalmology department with defective vision left eye since past 9 years. On examination, patient is conscious, coherent, cooperative, extraocular muscles, both eyes full and free in all cases, both eyes orthophoric, right eye best corrected visual acuity is 6.6 and left eye best corrected visual acuity is PL plus and PR plus in all quadrants, both eye anti-segment within normal limits. Ophthalmoscopic examination with slit lamp biomicroscope and 90D lens revealed right eye normal fundus and left eye fundus showed funnel-shaped peripapillary excavation and peripapillary striate vessels radially exiting from optic disc. Discussion. Morning glory disc anomaly is a congenital optic disc dysplasia in which there is a conical excavation of the posterior fundus, includes the optic disc and is filled with glial tissue. Morning glory syndrome is a sporadic and pathogenesis of this condition is unknown. Some hypotheses described by few others are failure of closure of the fetal fissure and primary mesenchymal abnormality, dysgenesis of the terminal optic stalk and primary neuroectodermal dysgenesis. Conclusion, morning glory disc anomaly are conspicuously more common in females and rare in blacks. Although it usually occurs in as a unilateral condition, bilateral cases have been reported. Treatment is directed towards preventing and treating the complications of retinal detachment. These are my references.
Good afternoon, everyone. I am Dr. G. Chandrakala. I am going to present a case report of Axenfeld-Rieger syndrome with normal intraocular pressure. Coming to introduction, Axenfeld-Rieger syndrome is an autosomal dominant disorder. It is associated with ocular as well as systemic developmental abnormalities. This syndrome occurs due to defects in differentiation, migration, or arrested development of neural crest cells. The most common ocular manifestations include a spectrum of posterior embryotoxin, iris atrophy, correctopia, and ectropia on uvea, with 50% of patients developing glaucoma. Mutation in PIT-X2, FOXC1, PARC6 have been reported to cause ARS. Systemic findings include dental and facial bone defects like maxillary hypoplasia, umbilical abnormalities, and cardiovascular abnormalities. Management primarily includes prevention of amblyopia and possibly the use of painted contact lenses for associated photophobia, surgical management of the glaucoma. Coming to the case details, history: a 17-year-old female came to MIMS ophthalmology department with complaints of defective vision in both eyes for 3 years. It is associated with watering and photophobia, not associated with pain, discharge and redness, associated with dental anomalies, not associated with any systemic abnormalities. Patient is having normal stature. Systemic examination: cardiovascular system S1 and S2 are heard, no murmurs. Respiratory system normal, vesicular breath sound. CNS system is normal, para-abdomen soft and non-tender. Local examination, facial symmetry is normal, head posture is normal, and extraocular movements full and free in all gauges. Ocular examination, visual acuity in right eye is 624 with glasses improving to 618, left eye 660 with glasses improving to 636. Color vision is normal in both eyes. Coming to the anterior segment examination, right eye, conjunctiva and eyelids and conjunctiva are normal. Cornea, posterior embryotoxin is present. Iris strands extending to peripheral cornea, and rest of cornea is clear. Anterior chamber is of normal depth, and iris is hypoplastic iris with vertically elongated pupil and clear lens. Left eye, eyelids and conjunctiva are normal. Posterior embryotoxin is present in cornea. Normal depth anterior chamber, hypoplastic iris, and polychoria correctopia are present with clear lens. Intraocular pressure measured with 80 at 10 am in right eye 14 mmHg and left eye 16 mmHg. On gonioscopy, all angles are open. Fundus examination, normal fundus in both eyes with mild tessellated background. Vitals are normal. Neurodevelopmental examination is normal. Electrocardiogram is normal. USG abdomen is normal. CT brain and orbits are normal. Based on the above findings, we arrive at a diagnosis of Axenfeld-Rieger syndrome. We advise patient glasses, painted contact lens or goggles, and genetic counseling and regular follow-up. Thank you.
Good evening everyone. My poster presentation is on case presentation of ocular manifestation of ichthyosis. Myself Bhavya Rajkumari. Introduction: to describe the ophthalmic manifestation in a series of children with congenital lamellar ichthyosis. These are presented with cicatricial ectopion, hyperkeratotic lesions, medarosis, trichiasis, scales on the lesions, lashes, meibomitis, abnormal movement of the upper eyelid, cicatricial lagophthalmosis, superficial corneal changes, and chronic retoconjunctivitis. The clinical features and the ophthalmic manifestations were studied. Methods: the case histories of all the 3 children presenting were reviewed. All are diagnosed with congenital lamellar ichthyosis. Examination of visual acuity, eyelid and eyelash malpositions, lid functions and closure were done. Corneal examination also done. Clinical features of the skin includes dry skin, scales, thickened skin, extra lines on the palms and soles, itchy skin, rough bumps on skins, unable to sweat enough. An ophthalmic finding includes eyelid scaling, cicatricial ectropion, conjunctival thickening, dot-like and flame-shaped opacities in pre-descendant membrane, nodular degeneration, band keratopathy, secondary corneal changes like vascularization and scarring from severe ectropion related exposure. Fundus examination on indirect ophthalmoscopy, both eye, media clear, optic disc size, shape, color normal, margin distinct, cuppus to disc ratio 0.4:1, blood and macula normal. Clinical implication: this case series of ichthyosis most commonly ocular finding is ectopion of both eyelids and no conjunctival involvement. The ocular complication of ichthyosis are not severe in majority of cases. However, some severe complications such as corneal perforation may occur. This is the case 1 of 9-year-old boy presented to the OPD with the complaining clinical feature. This is case 2 of 7-year-old male came to the OPD, and this is 6-month-year-old male. Thank you. And conclusion: congenital lamellar ichthyosis is a heterogeneous disorder. The most common eyelid abnormality is cicatricial ectropion of the upper eyelid and lower eyelid. Most cases were managed conservatively with surgical corrections. Thank you.
Good evening everyone. I am here to report a case report of Lawrence Moon-Bardet-Biedl syndrome. My name is V. Bhagyashree. Purpose is to report a classical case of Lawrence Moon-Bardet-Biedl syndrome. This syndrome is an autosomal recessive celopathy disorder presented early with clinical features like early onset night blindness with typical or atypical retinitis pigmentosa, post-axial polydactyly, central obesity, mental retardation, hypogonadism, and structural renal deformities. Other minor defects include speech hamper or slowdown, sensory neural hearing loss, ataxia, congenital heart problems, as well as hepatic fibrosis, brachydactyly, syndactyly, and diabetes mellitus. Other secondary features include polyuria, polydipsia, spasticity, short stature, crowding of teeth, hypermobile or lax joints, and early osteoarthritis, nystagmus, and constricted visual fields. Case report: a 14-year-old male patient reported to ophthalmology OPD with complaints of defective vision in both eyes since childhood, especially at night. He was a product of second-degree consanguineous marriage. Parents gave a history of similar complaints in the elder sister of the patient. His general physical examination revealed central obesity, post-axial polydactyly. Other minor features include initial motor and developmental milestones were delayed with commencement of walking and speech at 3 and 5 years of age respectively. Mental development is lagging behind by the normal range with IQ less than 70, and body mass index is 38, which indicates severe obesity. This is a picture. Here we can see central obesity and polydactyly. His ophthalmic examination revealed best corrected visual acuity is 1/16 both eyes. Fundus examination showed baxipale optic disc, attenuated retinal arterioles with peripheral pigmentary changes with mild night blindness and constricted visual fields. His parents were given genetic counseling regarding Bardet-Biedl syndrome. Discussion: Bardet-Biedl syndrome is named after George Bardet and Arthur Biedl. First case was reported in 1866. Most common mutated gene is BBS1. BBS proteins are components of the centrosome and affect the ciliary transport. Incidence is reported to be 1:160,000. Retinal dystrophy is the most common major manifestation. Conclusion: diagnosis of this syndrome is mainly clinical. To slow down the progression of pigmentary retinopathy, oral vitamin A palmitate was initiated at an early age. Thank you.
Myself, Bhavita. A case of Lawrence Moon Bardet-Biedl syndrome. 33-year-old male patient present to ophthalmology OPD with a chief complaint of progressive diminution of vision, more markedly at night from his childhood, history of polyuria, nocturia, polydipsia, history of loose stools, multiple foul-smelling watery stools, history of loss of libido, absent penile erection, history of delay of physical and mental growth. Past history: known case of genitourinary problems since 15 years, known case of diabetes mellitus since 2 years on regular medication. Family history: history of consanguineous marriage of parents. General examination: patient conscious, coherent, truncal obesity present. Ocular examination: both eyes nystagmus, both eyes hand movements present, both eyes antisegments within normal limit. Ophthalmic examination with slit lamp biomicroscopy and 90-day lens revealed bilateral pale waxy optic disc, arterial attenuation, hyperpigmented bony specules mid-periphery. Lawrence Moon Bardet-Biedl syndrome is a rare autosomal recessive genetic disorder involving multiple systems and had wide spectrum of clinical features. Characteristic features of this disorders are retinitis pigmentosa, polydactyly, truncal obesity, and learning difficulties. It may also associated with hypogonadism in male and complex genitourinary abnormals in female. Conclusion: because of the seemingly unrelated symptoms, the disorders remains largely underdiagnosis. Emphasis should be laid on spreading awareness about this condition as well round care by different specialties, and serial laboratory follow-up can ensure good quality of life in these individuals. My references.
Myself, Aisha Tansi. My poster topic is a case study on bilateral ectopia lentis in homocystinuria. Homocystinuria is a rare metabolic inborn disorder caused due to dysfunctional cystathione beta synthase enzyme activity. It results in elevated levels of methionine and homocysteine in blood and urine. It is an autosomal recessive disorder. Ectopia lentis is a rare ocular disorder with displacement of crystalline lens in the eye. Ectopia lentis is a major ocular complication of homocystinuria. Abnormal concentration of glycoproteins in homocystinuria weakens jonular fibers, causing bilateral inferior nasal displacement of lens and high myopia. The purpose of the study is to study the ocular findings associated with homocystinuria and for early diagnosis and to prevent complications. A 45 years old male patient came with complaints of defective vision in both eyes to OPD by his son. Slit lamp examination reveals bilateral inferior nasal subluxation of lens, no history of trauma, no history of consanguineous marriage. Lab investigations revealed high hyperhomocystinuria levels of 126 micromoles per liter. Ophthalmological findings in right eye: best corrected visual acuity is 660, retinoscopic findings -8 diopters, slit lamp examination showing displacement of lens to inferior nasal border, lens IMSC, fundus examination media hazy due to CLO, optic disc size, shape, color appears normal, margins distinct, A:2V 2:3, macula on, foveal reflex present. In left eye, best corrected visual acuity is 660, retinoscopic findings are -8 diopters, slit lamp examination reveals displacement of lens to inferior nasal border, lens IMSC, fundus examination shows media hazy due to CLO, optic disc size, shape, color appears normal, margins distinct, A:2V 2:3, macula on, foveal reflex present. A diagnosis of bilateral inferior nasal subluxation of lens in homocystinuria is made by the findings of the patient. Patient is advised to take pyridoxine 100 mg BD and methionine restricted diet. Homocystinuria is a rare 1 in 3 lakh population but can cause 90% of ectopia lentis in cases. The importance of early diagnosis by clinical examination along with blood tests and genetic tests. Early diagnosis helps in initiating the dietary modifications that arrest the progression of various complications associated with homocystinuria for better quality of life. Thank you.
Good afternoon, one and all. Today I am here to present a case about cavernous hemangioma of the orbit. The most common intracorneal benign orbital pathological lesion in adults is a cavernous venous malformation, accounting for 5 to 9% of all orbital tumors. Orbital cavernous venous malformation, previously known as cavernous hemangiomas, are benign, non-infiltrative, slowly progressive vascular neoplasm composed of endothelial lined spaces surrounded by fibrous capsule. Most CVMs are located in the muscle cone and in the area of the lateral wall of the orbit with progressive enlargement of thin-walled vascular channels, which leads to clinical symptoms. Chief complaints: a 51-year-old male patient presented with a painless, anterolaterally rapidly growing orbital proptosis of 30 mm in size in the right eye over 1 month duration with exposure keratitis. And the patient complains of rapidly progressive, painless loss of vision in right eye since 30 days with protrusion of eyeball. Along with lid retraction, patient is unable to close the eyelid completely, for which exposure of conjunctiva and cornea along with redness and watering of eye occurs. History of past illness: no significant history. Personal history: cigarette smoking and alcohol consumption since 30 years. And history of trauma to right eye 3 years back and 3 sutures applied to eyebrow. And here is the patient with proptosis. On general examination, patient is moderately built and moderately nourished. Ocular examination: uncorrected visual acuity, right eye perception of light negative and left eye 6:6, anterior segment right eye, upper eyelid retraction present, congestion present, exposure keratitis present, and anterior chamber, iris, pupils, lens obscure, left eye normal. On CT orbit, intracorneal right orbital mass with mass effect causing proptosis consistent with cavernous malformation, and with differential diagnosis: schwannoma, non-specific orbital inflammation like pseudotumor cerebri involving superior rectus muscle, bilateral maxillary sinusitis. Treatment: patient underwent right eye enucleation with tumor excision. Histopathological report: cut surface of soft tissue, cystic, firm with grey white areas. Section studied from the eyeball shows a lesional component composing of large dilated vascular spaces lined by flat endothelium filled with hemorrhage and separated by thin fibrous septa. Conclusion: surgical resection is always indicated in symptomatic patients. The aim of surgical treatment is total removal of tumor while at the same time preserving the optic nerve and muscular structures as much as possible. Thank you.
Good afternoon, one and all. Myself, Anusha. I'm here to present my poster on ocular findings in arachnoid cyst accompanied with orbital bone remodeling, a rare case report under the guidance of Jyotirmay ma'am. My purpose of the study is to report a rare case of arachnoid cyst in the left middle cranial fossa with ocular findings. Arachnoid cyst is a developmental anomaly which occurs due to splitting or duplication of the arachnoid membrane. It is 4 times more common in the boys than in the girls, and they are usually asymptomatic, but occasionally they may cause proptosis and neurological deficits due to cyst expansion or bleeding. Coming to the case report, a 11-year-old boy present with protrusion of the left eye since 10 years. The protrusion was insidious in onset and gradually progressive in nature since 10 years, and it attained the present size. Coming to the past history, it revealed an intracranial space-occupying lesion in the left middle cranial fossa, which was extending into the intraorbital region since 10 years. The birth history revealed a normal vaginal delivery, but the baby did not cry immediately after the delivery, and he was in NICU for 4 days. He attained all the milestones as per the age. Coming to the ocular examination, right eye best corrected visual acuity was normal and the anterior segment was within normal limits. Coming to the left eye, the uncorrected visual acuity was counting fingers close to the face and the lids showed severe lag of tone was present. Conjunctiva was quiet. Cornea showed a macular corneal opacity from 12 o'clock to 2 o'clock position in the periphery. Anterior chamber showed normal depth. Pupil showed relative afferent pupillary defect and the lens was clear. Fundus of the right eye as shown in the picture was absolutely normal, and the left eye, the positive findings include a pale optic disc and marked arterial narrowing. Coming to the left eye proptosis inspection part, it showed an unilateral eccentric proptosis with downward and inward deviation of the eye. There was no increase in proptosis on straining and no visible pulsations present. Severe lag ophthalmos present. Extraocular movements, there are complete restriction of movements in all directions. Coming to the palpation, orbital margins were intact and fluid-filled mass was palpable below the superior orbital margin. Insinuation of fingers was possible in all 4 margins. Proptosis was non-compressible and non-reducible. No bruit was heard. Head circumference was 26.5 centimeters. The MRI of the brain and orbits as shown in the picture suggestive of arachnoid cyst which was measuring 76 into 43 into 49 mm in the left middle cranial fossa, causing scalloping of the greater wing of the sphenoid bone. Coming to the discussion, the most common cause of unilateral proptosis in the children is orbital cellulitis. In rare cases, it is present since birth. Conclusion, proptosis secondary to the arachnoid cyst is a rare entity, so appropriate imaging technologies like MRI and CT are required. So timely referral to the neurosurgeon for the management of the arachnoid cyst and to plan for surgery if needed helps us to avoid further complications in this case. Thank you.
Good afternoon, one and all. Myself, Amulya, a postgraduate from Regional Eye Hospital, Visakhapatnam, going to present a rare case of Marfan's. Purpose: to report a case of Marfan syndrome. Introduction: Marfan syndrome is an autosomal dominant genetic disorder that affects the body's connective tissue. The cause of Marfan's is mutation in the gene FBN1 that encodes the fibrillin protein, which is a critical part of connective tissue. Connective tissue is present in all the parts of the body. Because of this, Marfan's can affect many parts of the body like heart, blood vessels, bones, joints, and eyes. Cardinal features for Marfan syndrome, as stated in revised Ghent nosology, include aortic root dissection and ectopia lentis with a scoring system of systemic features. Following is the clinical profile of one such case. Case report: this is a case of 32-year-old female which is a homemaker from Escota, came to our institute with a chief complaint of diminished vision of both eyes since 5 years, which is insidious in onset and gradually progressive in nature. On general examination, the patient was tall, slender and thin built, which shows arm span greater than height, with a kyphoscoliosis, pectus excavatum, arachnodactyly, and wrist sign is positive where the thumb is crossed across the little finger. On ocular examination, the best corrected visual acuity shows the right eye is 6/9 and the left eye is up to 6/9 partial. On anterior segment, the right eye eyelids are normal, conjunctiva is normal, cornea is normal, anterior chamber shows normal depth, pupil is normal size reacting to light, The lens shows grayish white and decentered superotemporally, which is shown in the image. And the left eye is normal. And the lens shows grayish white decentered superiorly. In on-fundus examination, both eyes normal. Discussion. Diagnosis of Marfan syndrome depends on a set of defined clinical criteria, gastroenterology, to provide appropriate diagnosis of the syndrome and improve management. Cardinal features of the new diagnostic criteria include aortic root aneurysm and ectopia lentis. In the absence of one of these two cardinal features, the presence of FBN1 mutation of positive systemic score is required. In our patient, due to the pending genetic and cardiology workup, the presence of ectopia lentis and a systemic score of 7 was attributed in making the diagnosis. Discussion. The most common ocular complication of Marfan syndrome is ectopia lentis. Abnormalities in fibrillin lead to jonular weakness with subsequent lens subluxation. Visual symptoms and treatment of ectopia lentis depends on the severity of the lens malposition. Prescribing spectacles are the first step to improve the blurred vision secondary to subluxated lens. In this patient, a conservative approach was done since it is achieved a good corrected visual acuity. Indications for lens extraction are inability to achieve good corrected visual acuity, posterior dislocation of lens into vitreous cavity, anterior dislocation of lens with or without secondary glaucoma, impending to complete lens dislocation, lens-induced glaucoma, uveitis and cataract. Thank you. Conclusion. A case of Marfan's with bilateral ectopia lentis with musculoskeletal and chest deformities was presented. Ophthalmologists play an important role in the diagnosis of Marfan syndrome due to ocular signs and symptoms. Patients should be evaluated with repeated refraction, monitoring of ectopia lentis, peripheral retinal status. A multidisciplinary approach is needed for monitoring and managing patients as to prevent the visual loss and life-threatening complications. Thank you.
Good afternoon, everyone. I am Dr. Ahmed Ali from GEMS College. I am going to present a case report of Florin-Moon-Bardet-Biedl syndrome. Introduction. It is a rare celiopathic pleiotropic autosomal recessive disease with prevalence of 1 in 1,50,000. Primarily affects the offsprings of consanguineous unions, with most commonly presented with night blindness. Presence of 4 primary features with 2 secondary features are the clinical grounds for making a diagnosis. The primary features are rod cone dystrophy, polydactyly, obesity, learning disabilities, hypogonadism in males, and renal anomalies. The secondary features are speech disorders, brachydactyly, developmental delay, polyuria, polydipsia, ataxia, poor coordination or clumsiness, diabetes, left ventricular hypertrophy, and hepatic fibrosis with spasticity and hearing loss. Case report. A 20-year-old male presented to ophthalmology OPD at GEMS Hospital with complaints of night blindness since childhood. Parents have given history of delay in milestones for verbal and motor. Similar complaints were seen in his elder sister. On examination, patient is conscious, coherent and cooperative. Truncal obesity with short stature is seen, and on systemic examination there is polydactyly seen in left foot. The central nervous system examination revealed low intellectual quotient and a GCS score of 13/15 was observed. He has normal high mental functions and intact gag and cranial reflex. The patient was unable to button his clothes, which is a marker of cerebral defect. Muscle bulk and tone are normal in all the limbs with regard to power and reflexes, and both lower limbs showed a power grading of 4/5. Plantar reflexes are bilaterally reduced. On genital examination, revealed a micropenis of approximately 2.5 centimeters, smaller than the regular scrotum of approximately 2.2 centimeters, with intact testis of pubic and axillary hair. Local examination, head posture is normal, facial symmetry is normal, and extraocular movements are full and free in all directions. Both eyes uncorrected visual acuity was 6/18 with correction BCVA is 6/9. On slit lamp examination, anterior segment is within normal limits. Fundus examination, media is clear in both the eyes. Optic disc is waxy and pale. Mild arterial attenuation with jet black pigmented bony spicules of mid periphery of the retina are seen, and the foveal reflex is dull. This is the picture depicting the retina, and here we can see the polydactyly and truncal obesity of the patient. The symptoms of clinical findings, family history and imaging studies are suggestive of Florin-Moon-Bardet-Biedl syndrome. Conclusion: Florin-Moon-Bardet-Biedl syndrome is a disorder with an identified pentad of symptoms, which are obesity, hypogonadism, intellectual impairment, polydactyly and retinitis pigmentosa associated with renal anomalies are the major cause of morbidity in these cases. Low vision aids help in visual rehabilitation. Genetic counseling of the affected families could not only warn them the possibility of having more children in future with the said condition, but also raise awareness about the need to get the other family members assessed for renal and cardiovascular problems. Thank you.
Good evening all. My name is Dr. Lavanya. A case presentation on bilateral full thickness macular hole in myopic eyes. Introduction. Macular hole is an important cause of central vision loss. It occurs due to full thickness defect in the center of macula involving the anatomical fovea. Risk factors include increasing age, axial length greater than 26.5 mm, refractive greater than -6 diopters, and Asian ethnicity. Estimated prevalence is 3.3 per 1000 people with cumulative incidence of 41.1 cases per 1 lakh per population. Object is to report the surgical challenges of operating on a case of bilateral full thickness macular hole in highly myopic patients. This is a retrospective case report. Results. A 62-year-old female with underlying high myopia presented with metamorphopsia in both eyes presented to our OPD. She had undergone uneventful bilateral cataract surgery 7 years prior to the current presentation. At present, her visual acuity was 6/36 with pinhole 636, near vision 24 in the right eye, and 624 with pinhole 624, near vision 18 in the left eye. Examination and investigations of both eyes shows full thickness macular hole with posterior staphyloma. Pars plana vitrectomy was performed twice over her left eye for the stage 4 macular hole, with first surgery failing to oppose the macular hole due to unavailability of forceps that was long enough to safe reach the posterior pole. Axial length of that patient was 31 mm. Other intraoperative challenges include pigmentary changes at small hole that was difficult in discrete. Fortunately, a repeat surgery involving usage of membrane blue stain with C3F8 gas for 3 minutes achieved symptomatic and anatomical functional success. She is planned for right eye macular hole surgery next. This is the picture showing posterior staphyloma of both right and left eyes. Discussion. High myopic eyes have higher chances of undergoing vitreoretinal surgery due to retinal pathologies such as macular hole, epiretinal membrane, and rhegmatogenous retinal detachment. Surgery in such eyes is challenging due to higher axial length, posterior staphyloma, thinner and atrophic retina, degenerated vitreous, thinner sclera, and abnormal scleral fibers. Conclusion. A-scan and B-scan ultrasonography should be performed for patients with pseudophakia undergoing macular hole detachment surgery who have history of high myopia previously. Due to increased axial length and posterior staphyloma, standard instruments may be too short for therefore unable to reach the retinal surface, especially for the posterior pole. This will result in reduced surgeon's maneuverability, erroneous contact with viewing system, longer and more challenging procedure. It is important for patients to undergo axial length measurement and B-scan ultrasonography to identify eventual posterior staphyloma to adequately plan the intraoperative approach. Thank you.
Good afternoon everyone. Myself Dr. Akanksha from Shankar Eye Hospital, Guntur. I am reporting a case of tuberculosis of lacrimal gland. The history of the patient is 39-year female patient presented to our OPD with chief complaints of swelling in lateral aspect of right eye upper lid since 1 month. The swelling was insidious in onset and gradually progressive. It was associated with mild pain. The patient was diabetic and on treatment since 1 year. On examination, the vision was 6/6 and around 6/4 mm swelling present in superolateral aspect of right eye upper lid. On palpation, the swelling was firm with smooth surface, mild tenderness. Finger insinuation test was negative. Anterior and posterior segment findings were within normal limits. So we did a CT scan. On CT scan, there was diffuse enlargement of right lacrimal gland, heterogeneous in attenuation with fat stranding and mild preseptal edema. So we had a provisional diagnosis of query infective dermoid cyst or lacrimal gland tumor. So we planned for right eye orbitotomy with mass excision biopsy under general anesthesia. 1 week postoperatively, patient was fine, wound was healing, skin was well opposed, and suture removal was done. Histopathological examination showed granulomatous inflammation with necrosis suggestive of tuberculosis. No acid-fast bacilli or fungal elements were detected in the special stains. Montague's test was positive around 25 mm. ESR was also positive for 25 mm, and chest X-ray and USG abdomen was within normal limits. We diagnosed it as a primary tuberculosis of lacrimal gland, and patient was started on anti-tubercular therapy by chest physician. Intensive therapy of 4 months and continuous therapy of 2 months was given. Follow-up after anti-tubercular therapy, patient had no evidence of any recurrences and the ESR was also fine. So, and discussion, orbital tuberculosis may involve soft tissue, lacrimal gland, periosteum or bones of orbital wall. Intracranial extension in the form of extradural abscess and infratemporal fossa extension can occur. Tuberculous dacrodenitis is an extremely rare manifestation of tuberculosis. The clinical presentation and gross appearance of tuberculoma of lacrimal gland can be similar to those found in benign mixed tumors. Histopathological examination plays a critical role in differentiating such swellings. Thank you.
Good afternoon everyone. This is a case of angle recession glaucoma. A 44-year-old male army officer came to the Jimser ophthalmology OPD with chief complaints of pain and blurred vision in the right eye since 10 days. HOPI. The present complaint started as pain, redness and blurred vision in the right eye, which is of sudden onset since 10 days and there is no progression. There is no history of photophobia and watering. There is a history of blunt trauma in the right eye with shuttlecock 1 year back, for which he was treated elsewhere by an ophthalmologist as right eye traumatic iritis with topical steroid drops and cycloplegics for 3 weeks. Past history. Known myopic with presbyopia, no history of diabetes, hypertension, CAD, CVA, TBA, TB and asthma. There is no family history of glaucoma. In the right eye, the visual acuity was 6/12 with pinhole not improving. Best corrected visual acuity is 6/9 with minus 0.75 spherical lens. Extraocular movements are full and free in all direction of all gazes. Intraocular pressure measured with applanation tonometry at 1045 recorded as 34 mm Hg. Conjunctiva. Diffuse conjunctival congestion is noted in right eye. Cornea, mild diffuse epithelial edema, anterior chamber, irregularly deep up at superior quadrant 11 o'clock to 1 o'clock region, normal depth in other quadrants. Iris brown, iris sphincter and iris pattern appears to be normal. Pupil round, regular and reacting, lens appears to be transparent. Gonioscopy, irregular widening of ciliary body band seen in superior and temporal quadrants. Fundus examination with 90D lens. Media is clear, 0.3 cup disc ratio and foveal reflex is dull. This is the picture of anterior segment. In the gonioscopy, we can appreciate the irregular widening of ciliary body band in the temporal and superior quadrants. This is the left eye gonioscopic picture which appears to be normal. Fundus photo is within normal limits. Diagnosis. The patient was diagnosed as right eye angle recession glaucoma secondary to blunt trauma. The patient was treated with acetazolamide tablet 250 mg BD for 5 days and travoprost at bedtime. Follow-up for every 2 weeks. Within, we have added 3 drugs for this patient which are travoprost, timolol and dorzolamide. Within the 3rd week, after 6 weeks, the applanation tonometry was recorded as 18 mm Hg. Thank you.
Good evening everyone. I am Dr. Tejashwini, my co-author being Dr. N. Ramabharti MS. My presentation is on visual prognosis in post-traumatic sclerolimbar laceration with iris and vitreous prolapse. Aim of the study is to report prognosis related to visual outcome in sclerolimbar laceration with vitreous in the wound site of an open globe injury. Methodology includes it is a prospective interventional study of an individual with deep sclerolimbar laceration with iris and vitreous prolapse at the wound site. Preoperative evaluation done under slit lamp, CT scan and MRI are done to rule out any fractures and impacted foreign bodies. Under strict aseptic conditions and antibiotic coverage, wound was explored under local anesthesia. A deep laceration of 6 mm length involving full thickness sclera and limbus at 5 o'clock position, which was sealed by conjunctiva, noticed with iris and vitreous prolapse. Iris abscission and vitrectomy were done, sutured with 10-0 nylon at limbus and sclera with 6-0 vicryl. These are the photos showing the injury site and the sclerolimbar laceration with vitreous. Results include On postoperative day 1 showed shallow but formed anterior chamber with iris peaking, and sutures were intact with surrounding conjunctival chemosis and hemorrhage. On postoperative day 7 with mild conjunctival congestion and decreased periorbital edema were noted. Sutures were intact with no evidence of inflammation or infection. Follow-up are done every 2 weekly up to 3 months, and also this patient underwent surgery for cataract after 4 months of sclerolimbal repair, and post-op day 7 vision was 6/24. Discussion include lacerations extending beyond the limbus and into sclera anterior to the equator, which are less deep, show better visual prognosis, but care to be taken at every step to prevent iatrogenic damage or further extrusion of intraocular contents. Wound boundaries should be carefully explored, foreign bodies checked, also for vitreous and uveal prolapse. Vitreous is cut flush with sclera to prevent traction on vitreous, and uveal prolapse corrected by hand over hand technique with interrupted sutures, meanwhile depressing the uveal tissue. Ocular trauma also causes cataract incidence angle recession, which should be taken care of. And I can conclude with early and prompt intervention like thorough evaluation, including careful and detailed slit lamp examination, Seidels test, early wound exploration and repair, maintaining globe contour, with appropriate treatment post-operatively to prevent end-off and sympathetic ophthalmitis yields better visual outcome. Thank you.
Hi, this is Dr. Shriya from SVS Medical College. My title is Outcome of Glue-Free and Sutureless Limbal Conjunctival Autograft for Primary Pterygium Excision Surgery. Introduction. Pterygium is defined as a degenerative ocular surface disorder with wing-shaped fibrovascular growth of the subconjunctival tissue onto the cornea. The epithelium may be normal, thick or thin, but it may occasionally show dysplasia. A small pterygium can only cause slight irritation, cosmetic blemish, and slight heaviness or redness in the eye, but if it gets advanced, it may cause impairment of vision. A number of surgical techniques have been described for management of pterygium, which include bare sclera resection followed by mitomycin C application, pterygium excision plus conjunctival autograft, or amniotic membrane placement. Materials and methods. In this study, autologous limbal conjunctival autografting was done without sutures and glue, which is represented by group 1, and the results were compared with those obtained with sutured autograft, and it is named as group 2. Inclusion criteria: patients of all ages and sexes presenting with primary nasal pterygium. Exclusion criteria is recurrent pterygium, temporal pterygium was not included, glaucoma, retinal pathology requiring any surgical intervention, history of previous ocular surgery or trauma. Surgical techniques: peribulbar anesthesia with 2% lignocaine and 0.5% bupivacaine was given preoperatively. The body of the pterygium was dissected 4 mm away from the limbus down to the bare sclera. Pterygium was removed from the cornea by avulsion. Only thickened portion of conjunctiva and the immediate adjacent subadjacent Tenon's capsule showing tortuous vasculature were excised. Large hemorrhages were tamponade with direct compression, cauteries avoided. Oversized graft by 1 mm was used after measuring with Castroviejo's caliper. The graft was taken from 12 o'clock position. Results: a total of 50 eyes of 50 patients were studied. Here there is table 1 or figure 2. Demographic profile of the study population, where group 1 represents glue-free and sutureless pterygium, while group 2 represents sutured pterygiums. And both of them are in the age between 25 to 75. Figure 3 represents first post-operative day and post-op 3 months of sutureless and glue-free flap, while figure 4 represents first post-op day and post-op after 3 months of sutured flap. Table 5 is a comparison between two groups that represents an average surgical time, while group 1 and group 2 takes longer duration, post-operative symptoms are more, that last for about 4 weeks associated with graft edema, and group 1 is less surgical time, post-operative symptoms are seen in about 20% of the patients that last for about 2 weeks, and graft edema is seen in only 8% of the patients. While performing the surgery, it should be kept that not only excision of the surgery is important, but also reoccurrence should not happen. So whenever we put on a graft, that will actually help in restructuring the limbus, so there is no recurrence usually. Conclusion: Sutureless and groove-free limbal conjunctival autograft is a new novel technique for treatment of primary pterygium. Not only the surgical time required is less, but also the complications encountered are fewer than suturing technique. Moreover, the feasibility, absence of cost factor, suturing process, and potential adverse reactions encountered with the use of foreign material to make it superior to suturing. More research with longer follow-up is required to add the knowledge about both of the techniques. These are the references. Thank you. I hope everybody had a good nap while I finished my presentation.
Good evening everyone. Myself Dr. Sri Charita. My title is to assess the clinical features of dry eye in thyroid associated ophthalmopathy. Aim is to evaluate the clinical features of dry eye in thyroid associated ophthalmopathy. Methods: 42 eyes of 22 patients with TAO and 80 eyes of 40 patients without TAO were included in this prospective study. Schimmer's test was done and assessed. Results were then compared with the patients with TAO and without TAO. While comparing these two groups, irritation, foreign body sensation, itching, proptosis, ocular discomfort was present in group 1 patients, and in group 2 all of these were absent except the proptosis, which is present in both the groups. Mean Schimmer's test is 13.4 plus or minus 7.32 mm and 23.9 plus or minus 4.57 mm in group 2 patients. Discussion: two groups were taken, and group 1 which included 22 patients and group 2 which included 40 patients. And the clinical features of dry eye such as irritation, foreign body sensation, itching, proptosis, ocular discomfort were assessed. Schimmer's test was done in both the groups. This test measures total tear secretions. It is performed with the help of a 5 into 35 mm strip of Wartman 41 filter paper, which is folded 5 mm from one end and kept in the lower fornix at the junction of lateral 1/3 and medial 2/3. The patient is asked to look up and not to blink or close the eyes. After 5 minutes of the wetting of the filter paper strip from the bent end is measured. Normal values of Schimmer's test are more than 15 mm. Values of 5 to 10 mm are suggestive of moderate to mild keratoconjunctivitis sicca, and less than 5 mm is suggestive of severe keratoconjunctivitis sicca. Thyroid ophthalmopathy. Thyroid ophthalmopathy is an autoimmune disease in which autoantibodies against the thyroid stimulating hormone receptor are produced. Clinical features of TAO include exophthalmos, retraction of the eyelids, and restriction of the eyeball movements. Dry eye. The trigger mechanism of dry eye in patients with TAO is exophthalmos, retraction of eyelids, and the fibrosis of the levator palpebrae muscle. Reduced tear production and changes in tear composition are associated with the dry eye. Result: the mean Schimmer's test was 13.4 plus or minus 7.32 mm and 23.9 plus or minus 4.57 mm in patients with TAO and without TAO respectively. The mean proptosis did not show any difference between the TAO. Conclusion: dry eye is common in patients with thyroid associated ophthalmopathy. Thank you.
Good afternoon to one and all present here. I'm Dr. Lahari and I'm going to be presenting a case report on drug-induced acute angle closure glaucoma. So coming to the introduction, several systemic and topical medications may induce acute angle closure glaucoma, which is an ophthalmic emergency, and it acts via two mechanisms. One is the pupillary block mechanism and the other is the non-pupillary block mechanism. Medications implicated can be topical cholinergic drugs, sulfa drugs, and antipsychotic drugs, amongst many others. Coming to the case report, a 43-year-old female patient came to the emergency room with chief complaint of headache, which was holocranial, severe, and associated with nausea and one episode of projectile vomiting without neck stiffness or fever. Patient was admitted under neurology for headache and was diagnosed as migraine, and she was started on tablet pregabalin 75 mg plus nortriptyline 10 mg once daily at night, tablet thiacolchicide 8 mg and aceclofenac and paracetamol combination twice daily, and capsule duloxetine 20 mg once daily, along with an IM injection diclofenac stat. She developed blurring of vision both eyes the next day after using one course of prescribed medication, which was sudden onset, bilateral, painful, with redness of eyes and associated photophobia. She was a known hyperopic and a known case of migraine since 5 years and was started on tablet naproxen sodium 500 mg SOS, tablet gabapentin 75 mg and duloxetine 20 mg once daily, which she has been using on and off. On our ocular examination, best corrected visual acuity in the right eye was 6/24 and 6/18 in the left eye. Conjunctiva showed circumcorneal congestion in both the eyes. Cornea showed diffuse epithelial edema and corneal sensations were present. Anterior chamber was shallow with 1 Herix grade 1. Her pupil was 3 mm in size and sluggishly reacting to light in the right eye while it was briskly reacting in the left eye.
Fundus media were hazy and 0.4 cup disc ratio was noted. On applanation tonometry, 56 millimeters of mercury pressure was noted in both the eyes. Gonioscopy, we could not visualize the angles due to corneal edema. Beside are the pre-op pictures showing a shallow anterior chamber. As part of our management, the patient was asked to stop medications for migraine immediately, namely gabapentin, nortriptyline, and duloxetine. Treatment given was tablet acetazolamide 500 mg stat, and an IV mannitol infusion of 1 gram per kg was given over 20 minutes with vital monitoring. However, her post-infusion IOP measure was only 42 millimeters of mercury in both the eyes, even 1 hour after infusion. She was immediately started on anti-glaucoma medication, and IOP after 1 day of treatment was 18 millimeters of mercury. However, gonioscopy at that point also showed closed angles in both the eyes. She was then planned for a laser peripheral iridotomy under 2% pilocarpine. Beside are the pictures showing the transition from a pre-op state to a post-LPI state. After LPI, she had 18 millimeters of mercury of intraocular pressure and partially open angles. Over here, we can see on the follow-up day, which is 3rd day after LPI, her intraocular pressure was once again noted to be 10 millimeters of mercury, and angle was anterior chamber depth was normal in this state, and gonio also showed partially open angles. Conclusion: this is a case of primary angle closure with occludable angles which developed acute angle closure glaucoma due to migraine medication, namely tablet duloxetine, pregabalin, and amitriptyline. Preventing such attacks is important, and screening should be advised while prescribing implicated medication. Thank you.
Good evening all. I'm going to present, I'm myself Sona Babu, coming from Anandapur Medical College. I'm going to present my case report on golden horse syndrome. It's a rare congenital disorder affecting the first and second brachial arches. It's characterized by a triad: mandibular hyperplasia, vertebral anomalies, and ocular and auricular anomalies. Coming to the case details, a 4-year-old girl child which was presented with a limbar nodule in the left eye since birth. It was gradually increasing in size. It was the first born child of the non-consanguineous marriage, and with a normal birth history and no significant family history. General examination, facial asymmetry was present, mandibular hyperplasia, micrognathia, skin tag was present in the left cheek, and pre-auricular tag was present in the left ear. On ocular examination, the right eye was absolutely normal. The left eye, in the anterior segment, limbal dermoid was present on the temporal side, which is on 4 to 5 o'clock position, and the size was 4 to 5 mm, which was circular in shape, and color was yellow in color, and surface was smooth. The posterior segment was within normal limits in both eyes. So on systemic examination, it was also normal, and in X-ray spine, we have observed mild kyphoscoliosis. Coming to the conclusion, the patient was advised for the frequent follow-up and pediatric and orthopedic consultation, and golden horse syndrome is easy to diagnose based on the clinical appearance without excluding further investigations. Limbal dermoid should be excised if they cause strabismus, followed by appropriate refractive correction to avoid amblyopia. Thank you.